activate a muscle, or we're going to release a neurotransmitter, which is a amplitude modulated output. So it's kind of funny the way it works. So how does it actually propagate? How does it actually move? And so if we depolarize artificially a segment of the neuron, we basically are going to get a propagation which is going to be in both directions. The reason it doesn't occur naturally is because of the refractory period that we just looked at because of the potassium. Okay? And so it turns out that one little segment depolarizes the next segment on down, can't re-enter because this is still refractory. And so we get a conduction of this regenerative action potential that moves, down the axon. Well, one of the things that you have to memorize for this class is you have to memorize that the conduction velocity of a myelinated axon is approximately 5 times the diameter in microns. And the conduction velocity for a non-myelinated axon is about 1 times the diameter in microns, measured in meters per second. So a 1 micron diameter myelinated axon conducts at approximately 5 meters per second. Unmyelinated is roughly an order of magnitude less, 5 times roughly less than the myelinated conduction. Now, why is myelin important? Most of our axons actually are myelinated. And so why is that important, and what mechanisms are involved in that conduction? And so we're going to look at that question in more detail here. Well, it turns out that when you have an insulation around the axon, it increases the membrane capacitance. Okay? Sorry, it actually decreases the membrane capacitance, and increases the membrane resistance locally, so that the signal actually will jump from one node of Ranvier to the other. That's called saltatory conduction. Okay? So myelin is, because it's an insulator, it's going to make the capacitance of the membrane be much less. Okay, it's going to increase the membrane resistance with the insulator. And because of that, the depolarization doesn't have to occur where the myelination is. It can actually jump from one exposed point on the neuron to another. So from what we just talked about, let me ask this question real quick and I'll come back. From what we just talked about, what does that mean about the spacing of the nodes of Ranvier in terms of the lambda decay constant? They have to all be within a lambda decay constant, right? Or else it's not going to work. So if you look at the spacing, it's very, very much within that kind of lambda decay constant. Now the question in the back. You got it. Okay. So here's an example where we have an axon here. This is the axon. You can see the neurotubules. See all the little neurotubules? And mitochondria, a lot of mitochondria. And then here's the cytoplasm of the Schwann cell. So the Schwann cell just wraps itself in this spiral fashion around the axon and insulates it. So it's a mechanism that increases conduction velocity. Why is increased conduction velocity advantageous? Because you want your axons to be really, really fast or really, really slow conducting. Yeah? So, I mean, if you're getting chased by a bear or something, the faster you can, get away, I mean, that gives you a survival advantage. So, I mean, there are a lot of advantages. It makes you think better. It's actually critical, for seeing if you don't have a myelinated optic nerve, you're blind, which is obviously a disadvantage. So, there are a lot of reasons why, myelin is very important. So it increases conduction velocity. It also allows us to pack a whole bunch of neurons tightly. And so one of the things we studied, I had one graduate student that wrote a whole dissertation studying the conduction of squid axon. And these are really funny creatures to study. I mean, we went down to Galveston and we bring back this huge thing full of squids and we try to keep them alive. And we start operating on them and they squirt ink all over you. There's all kinds of cool things that you have to put up with. But anyway, the giant squid axon is a great experimental model because it's really big. It's the bigger axons, but it's non-myelinated. And so a lot of what we know about modeling neurons kind of comes from studies on that. So it's a very good experimental model. It really doesn't work too good. If you had all of your axons that look like squid axons, your median nerve would be this big. That would be obviously not an advantage. So myelin allows us to pack in lots of fast conducting neurons in a very small space. So it gives us that huge advantage there. So here's another thing we study in the lab. There's a genetic mutation called the sugar mice. And so we study these as an example of what happens when neurons become demyelinated. And so here's an example in the upper panel here of myelinated. This is a myelinated, optic nerve. And this is a non-myelinated optic nerve. And so it turns out that the myelin decreases the energy consumption of the neuron. And because you're not having to do the voltage-gated sodium potassium channels in a continuous way, it just happens in your nodes of Ranvier. And so you get a huge energy savings. And remember what Amy taught you, and I've told you too, that the majority of the energy expenditure of neurons is in maintaining that sodium-potassium pump. And so it turns out when you demyelinate a neuron, it dies. Okay, so we use this in the way that we kind of study the natural death in neurons. So you take an optic nerve, and these poor mice are born without myelin. They're all blind. They can't see anything. And the neurons don't survive because they're not myelinated. So myelin is not only important in terms of conduction velocity, but it conserves energy and is essential for our axons to survive. So there are a couple of important diseases that we need to know about. One is called the Guillain-Barré disease. Any of y'all have ever had Guillain-Barré or known somebody that had it? Nobody? Ever heard of it? It's very common. This year here at the university, there will be at least 2 or 3 cases, and it affects your age group, more than 9. Okay, so you might want to know about it, right? So Guillain-Barré is a progressive peripheral neuropathy. The typical kind of story about Guillain-Barré is somebody has a mild case of the flu and they get over it. And then for whatever reason, maybe 2 or 3 days after you kind of get over the flu, go back to class, you notice that you just don't have normal muscle strength in your legs. You may have some paresthesias, a little tingling in your legs. And then over a period of hours, it kind of progresses up your tummy, and then maybe you start getting a little tingling in your hands. Okay? And you get progressive weakness in your lower extremities. Y'all ever heard of Guillain-Barré? No. So, I can tell you, kind of, just to give you a little bit about the pathophysiology in these slides. This is actually from a patient that didn't make it. And so, what happens is it demyelinates the peripheral nerves. We don't know exactly why it happens, but it's probably an autoimmune cross-reaction to maybe some membrane proteins in a virus. We think that that's kind of the way it works. You can also get it if you're vaccinated. About 1 in every 100,000 people that gets a vaccine of unspecified type will actually end up with Guillain-Barré. So that is one of the very small risks that you take when you have vaccination. Yeah.
Is it a permanent condition or does it go back?
What?
Like, is it permanent or is it usually cause death?
Yeah, we're kind of getting to that in just a minute. So you haven't answered my question yet. So you had the flu, and you got this kind of, a little bit of weakness in your legs, you get some tingling. What do you do?
Go to the doctor.
Take an aspirin and go to bed? Evelyn, what do you
Drink a beer.
Okay, so the bottom line is you'll die from this, okay? It's a serious problem because, you get this progressive peripheral polyneuropathy. Basically, your peripheral nerves are being now demyelinated by your immune system. And when it gets up to your phrenic nerve, which controls your breathing, that gets to be really serious because you quit breathing, right? And so somebody that has Guillain-Barré, and you diagnose it just by the symptoms that I just described for you, there really aren't any good lab tests. But if you have that picture, flu followed by paresthesias and weakness, you really need to go to the emergency room. And the doctor in the emergency room actually, when they make the diagnosis, should at that point admit you to the neurological intensive care unit, because there is a fair chance that you're actually going to have to be intubated. You have to be put on a respirator, until your body kind of gets over the problem. Everybody that can be supported survives. Okay, this is a survivable disease as long as you don't, neglect it. So it's important to recognize it and then go to the emergency room and in the intensive care unit. The doctors and nurses can monitor you, and if you get to where your phrenic nerve is involved, they can put you on a respirator and artificially breathe you until you get over it. But to get back to your answer, most everybody gets full recovery. There are exceptions. The older you are when you have it, the less positive the outcome. Yeah.
What in a vaccine causes it?
We don't know. That's something for you to figure out. It's probably that flu virus, for whatever reason, causes your immune system to cross-react with a protein that's in the virus capsule that cross-reacts to the Schwann cells, or the myelin, the actual composition of myelin, and starts destroying it. And so this is what it looks like, when your myelin gets destroyed.
So how long does it take to recover?
About 2 weeks.
How fast acting is it? Like, from the point that you can start feeling in your feet? Like,
From the time you get tingling in your feet to the time you're really in trouble is about 8 to 12 hours. How do you get over it? Well, you have to be supported. That's what's called supportive care in the neuro ICU. So if it goes high enough and you get your phrenic nerve, which is C3, 4, and 5, if you get the phrenic nerve, then you have to be on an artificial respirator until your body kind of naturally gets over it.
How did the cross-reaction stop?
Well, that's another good question. I don't know why it stopped. Now, there are some people that suggest that if you have this, maybe one thing you could do is plasmapheresis. High-dose steroids don't help. There's just supportive care. Okay? That's Guillain-Barré. Something to think about next time you have the flu. Or get vaccinated. Do y'all get vaccinated?
Not anymore.
Yeah, actually, if you stop to think about it, there is so much more reason to get vaccinated than not. So I'm not making this as a pitch to not get vaccinated. Remember I said it's 1 in 100,000, so I mean, it's very, very rare. Most people get over this anyway. So if you don't get vaccinated, you know, the whole population loses its herd immunity. Have y'all heard about that? Herd immunity? And if you don't get vaccinated, then all of these terrible things like meningitis and pneumonia and other things can cause way, way more problems than the Guillain-Barré. Another important disease that is in this category of demyelination. So another thing that we know is a bad problem that occurs because demyelinate parts of your brain is a disease called multiple sclerosis. Have y'all heard of multiple sclerosis or known somebody that had MS? Tell me about it.
People lose their, motor skills.
That what?
I think they lose their motor skills.
Lose your motor skills? You can. But who do you know that has MS?
I knew someone who
Okay. Anybody have?
I just know it's part of the
Anybody knows, because of a close relative or a close friend or somebody that has MS? Anybody? Yeah.
I don't know super well, but one of my grandparents, close friends, have it.
Okay.
Has it. Like you were saying, the motor skills is an issue. Just getting around and everyday activities become pretty hard.
Activities become hard.
Everyday activities.
Motor skills can decrease. Anybody else? Okay, well, it's quite common. I feel confident everybody here will know somebody or come across patients that have MS. And so the profile for the MS patient is a Caucasian female between the age of 20 and 30, otherwise healthy, that lives in kind of where we live, in more temperate climates. It's less common if you go way up to the Arctic and less common if you go down to the equator. So we're in the right geographical area to North America to get MS. So female, 20 to 30, Caucasian, yes.
I was just wondering, is it in this area because of the genetic composition of this area or something about
Well, that's a good question. So let's talk about that since you asked the question. So it turns out that definitely there is some genetic predisposition. So if you do twin studies, the twin has it, and if you as a twin, your twin has it, you're at about 15% risk. So it's not 100%, but there's certainly a higher risk if you have a mom or dad or a sib, and especially an identical twin that has the disease. Not 100%. And so, one of the big questions is, how much of this is genetic predisposition and how much of this is exposure to something that's in the environment. Okay? And so epidemiologists they have studied this and studied it and studied it and studied it and still can't come up with a specific environmental cause. Okay, there are a lot of possibilities, but they range from underarm deodorant to pine trees. There's a high correlation actually between MS and living in an area that has pine trees. Okay. So anyway, we don't know for sure, but it definitely has some genetic predisposition, plus probably some epigenetic kind of environmental influences that kind of trigger the disease. We know it's an autoimmune disease. The body makes an antibody that actually attacks the myelin sheath on, unlike Guillain-Barré, which is peripheral nervous system, MS attacks the neurons inside your central nervous system. So the way we diagnose this is with an MRI scan, and we look for these plaques, and it happens all over. And so the typical way that MS patient actually presents, so again, female, 20 to 30, Caucasian, the most common way that they present is to me. Okay? As an ophthalmologist, I am the gatekeeper for MS. So anyway, what happens is the most common presentation is a 24, 25-year-old Caucasian female has sudden loss of vision in one eye. And it's called optic neuropathy. So what's real interesting is these patients come in and they're all very laissez-faire about it. Basically, it's, oh, doc, you know, I just lost vision in my eye, but it's okay. I can still see with the other eye. Okay? And you think, well, that's kind of strange. You know? You're not really that concerned, you know. And so you do the test, and you know, in 2020, and do this when they're 2400, you know, can't see anything. And so once we see this, we send them over and get an MRI scan, and that's the way you make the diagnosis. We look for these plaques in the brain. And in this case, we'd be looking at the optic nerves. We'd be looking for optic neuropathy. And they all get better. We don't have to do anything. They'll get better. And you say, you're okay, you know, you'll get better. And sure enough, 2 or 3 weeks later, you know, the vision starts coming back. And, you know, it comes back pretty much normal. It gets back to almost 20/20. But then it happens again and again and again. And once it starts hitting the optic nerve, it'll start hitting the part of your brain that controls your muscle function. So you may have weakness, tingling in your arms or legs. It, you know, is a relapsing, gets bad, gets better, gets bad. But the general trend is down. And there are various forms of MS, but the more typical kind is the relapsing, we call it the relapsing MS. And so we tend to see these patients get better, get worse, get better, get worse. And generally, there's kind of a downward trend. In general, people with MS die about 10 or 15 years younger than people that don't have MS. They suffer from all kinds of disability, which can be incontinence, autonomic dysfunction, depression. People that have MS usually have significant depression. There can be some cognitive impairment. And so people that have MS typically are not, you know, winning the Nobel Prize, but, you know, it's one of those things that, you know, it's just kind of a general, it's not like that, it's just kind of a general decline. Yes?
What causes those plaques?
We don't know. I mean, I can tell you it's an autoimmune reaction, but, you know, it's a demyelination. So the reason you get that white spot is because the blood-brain barrier has been breached. So you get these antibodies that go in, and they start the leukotriene cascade, which produces vascular permeability, and then you get white blood cells that get in, and so that creates this plaque, inflammatory plaque in the brain, and it goes away. So if you look, 3 months later, that white spot will be gone, but it leaves a little residual damage. It's never complete recovery. Yeah. So that's a great research area. I mean, this is stuff we don't know what causes it. We don't really know how to treat it. We have some things that we give people with MS, but they're pretty ineffective. Yeah. So this is a good thing to kind of work on as a project. Okay, so let me kind of go over a little bit a couple of things that may be important to kind of understand in terms of how we calculate conduction velocity and why conduction velocity is related to the diameter of the neuron. I can prove that to you. So if we go back to the Hodgkin-Huxley model here, You know, it's got all of the different, batteries and conductances for the sodium, potassium, and chloride. It has the sodium, potassium pump, has the membrane capacitance, and of course, this repeats and repeats and repeats. When I do an AC analysis of this circuit, as an electrical engineer, I can take, if I know that this is, I'm going to just do an AC analysis. It turns out that for AC analysis, all of the batteries look like shorts, all of the current sources look like opens. And so when I open up the current sources, they go away. The batteries look like shorts. I combine all the conductance into that one membrane resistance. I end up just with the current source, which is my depolarizing current, and the membrane capacitance. That's all I have left. When I do, as an electrical engineer, I am a reductionist, and I reduce the top circuit into the bottom circuit. I also know that I can flip back and forth. I can do Thevenin and Norton equivalents, so this is identically the same as the Thevenin equivalent. So I have the Norton here and the Thevenin here. I can analyze them. I just am more comfortable analyzing batteries and switches. And basically, when I take a battery with a switch and I put the switch on, and it turns out that it takes time for the capacitor to charge. And so I can have a certain amount of current, which is instantaneous. That's my input. And then this is going to be the response. It's going to be this voltage here. Okay? That's this from your circuit theory. Now, remember I told you I was going to come back to these incremental membrane capacitances, incremental membrane resistance, and incremental axoplasmic resistance. And so when I look at the scale of the events that occur as I propagate an action potential, it turns out that axoplasmic resistance is 3 or 4 orders of magnitude less than the membrane resistance. And so when I go through the formal calculation here, whenever I have this being much, much less than this, it turns out that for all practical purposes, I end up just with this ED and R axon. And so I basically just end up with this voltage here and this R axon. Okay? That's that little R axon. If I sum them all up, it makes the big capital R axon. And if I look at what happens in terms of depolarization, it's this exponential curve whenever I close the switch. And so we know that this creates a delta EM, call it EM. It's a change in membrane voltage, which depends upon this time constant right here. So I have an E to the minus T over little r axon C membrane. Well, it turns out that if you remember that the membrane capacitance, so you basically think of it as a parallel plate capacitor, the capacitance is epsilon naught A over D. Okay? D is going to be the thickness of the myelin. And so as I increase the thickness, my capacitance is going to get smaller, my membrane resistance gets bigger. And if you go back and you look at the equations that dictate that, it turns out that the incremental axoplasmic resistance goes as 1 over D squared, and C membrane goes as D. Okay? Again, because it's a parallel plate capacitor. Okay? And so it turns out that the membrane depolarization constant decreases and conduction velocity increases in proportional to D. Another way to look at it, I just gave you another little formalism here, but basically the K constant is inversely proportional to the diameter, and conduction velocity is inversely proportional to the K constant, the depolarization time constant. One last thought before we leave here. If I take a nerve, okay, this is important, so follow through with me here. I have a nerve, and I stimulate the nerve, and I look at the response that I get with the nerve. I get a whole bunch of different peaks. The faster ones are going to be very quick. The faster ones are going to be myelinated, large diameter neurons. And then finally, the very slowest are going to be small, unmyelinated So if I start and I look at increasing thresholds of what I get, this is as I increase thresholds, I get the biggest and fastest ones first. They're going to be there all the time. And eventually, as I get higher and higher threshold stimulation, I'm going to get some of the smaller neurons in my nerve. This is called a compound action potential. So this is what you see when you stimulate a nerve, not a neuron. Okay? You get a distribution of conduction velocities, with the biggest being the fastest, okay, and the smallest being the very slowest. Okay. We'll stop here and start next time.